Modern-day phacoemulsification has evolved into refractive cataract surgery, with patients desiring perfect outcomes. Premium IOLs, including toric IOLs, multifocal IOLs, and extended range of vision IOLs, are being increasingly implanted to help achieve spectacle independence at all distances with excellent visual quality. Proper patient selection, precise hour power calculation, and a well-centered IOL placed within the capsular bag are prerequisite to achieving optimal outcomes in these premium IOL implantations. But what do we do when things don't go as planned? Posterior capsular rupture is a dreaded intraoperative complication encountered during phacoemulsification surgery. It becomes even more problematic when it occurs in a case planned for a premium IOL implantation owing to high patient expectation. A ruptured posterior capsule, however, does not necessarily preclude the implantation of premium IOL. PCR most commonly occurs towards the end of phacoemulsification, at the time of emulsification of last nuclear piece, during cortical aspiration, after IOL implantation, or even during viscoelastic aspiration. Depending on the size, configuration, location, as well as the stage of surgery at which PCR occurs, there are various techniques that allow the implantation of a single-piece foldable IOL. These include placing the IOL in the back in cases with a small central PCR with intact vitreous face, converting the tear into posterior circular capsular rhexis, reverse optic capture, placing it over the anterior rhexis, or injecting the single-piece IOL in the sulcus, followed by tucking the haptics in the back. Key surgical principles that needs to be adhered for implanting a premium IOL within a capsular bag in the presence of ruptured posterior capsule include the prompt recognition of PCR, avoiding sudden chamber decompression or collapse, use of appropriate OVD, and stabilizing the single-piece IOL. We present a spectrum of case scenarios wherein a premium IOL was successfully implanted despite the occurrence of posterior capsular rupture. In this case, a 55-year-old patient was planned for a femtosecond laser-assisted cataract surgery with toric trifocal IOL implantation. A large PCR was observed during irrigation aspiration after implantation of the IOL in the bag. As soon as the PCR was recognized, visco-dispersive OBD was used to tamponade the tear, and subsequently, gently bimanual technique was used to capture the optics from either side, above the anterior capsular rhexis. On completion of optic capture, the intraocular lens was stable and the anterior rhexis margins attained a quadrangular shape due to peaking at 4 corners. In this case, planned for a phacoemulsification with toric IOL implantation, a small triangular shaped PCR was observed after implantation of IOL during the OBD aspiration. The second instrument was removed first, followed by the injection of OBD to maintain the chamber. Visco-dispersive OBD was injected in the areas of PCR beneath the IOL to cushion the anterior vitreous face. The intraocular lens was then aligned along the correct axis and left in the capsular bag. In this case, planned for a phacoemulsification with toric monofocal IOL implantation, a large central posterior capsular rupture was observed at the end of cortical aspiration. A dispersive OVD was injected over the PC defect to avoid injecting directly through the capsular rhexis with an open posterior capsule. The intraocular lens was first placed in the sulcus. Both haptics were then tucked beneath the anterior rhexis while aligning the toric IOL along the required axis. A reverse optic capture was performed to stabilize the intraocular lens. All cases had an uncorrected visual acuity of 6 by 6 on a post-operative day 1 with a well-centered IOL which maintained stability subsequently. Implantation of premium IOL within the bag may not always be feasible in cases with PCR, and a multi-piece IOL implantation in the sulcus should be considered in these scenarios. These include cases with large PCR with insufficient support or an extension of anterior capsular axis. Premium IOL implantation can be performed successfully even in the presence of intraoperative posterior capsular rupture. In a well-selected cases, reverse optic capture is a useful technique to stabilize a premium IOL. In such cases, post-operative intraocular pressure management is important as complete removal of viscoelastic may not be feasible. Prompt recognition and judicious use of OVD can help us achieve optimal outcomes in patients with PCR planned for a premium IOL implantation. Thank you very much.
No questions now. Okay. Can we have VT93? VT9?
No, एक minute. She wants to go for a.
Okay. What is the number?
The big boom of minimally invasive glaucoma surgery has revolutionized the surgical management of glaucoma. It has created a new era in the world of precision medicine in the fast developing world. They are minimally traumatic with high safety profile, moderate IOP lowering and rapid recovery. They act through the conventional outflow pathway via the Schlemm's canal. These procedures target various sites like the trabecular meshwork, suprachoroidal space, subconjunctival space, etc. The device-based procedures like Zengel stent, Hydra stent are limited in our country by their expensive nature and limited availability. The trabecular meshwork-based procedures like GAT, bang and trabeculotomy are readily available as well as economic. These array of MIGS procedures have added more safer options to our armamentarium. It may be tough to begin with, but it is crucial to start. In this video, let's capture the key for a perfect MIGS by exploring the nuances of intraoperative gonioscopy. A well-prepared battle is half won. With adequate preparation and practice, the learning curve can be easily shortened. The surgeon preparation begins by performing gonioscopy in clinic, identification of landmarks, and adequate intraop gonioscopy practice prior to starting any minimally invasive glaucoma surgery. Beginners should select patient with care, having good neck mobility without head tremor, with good cooperation and visible angle in the clinic. Begin by tilting the microscope 30 degrees towards the surgeon and rotate the patient's head 30 to 35 degrees away from the surgeon. Patient should be in a reverse Trendelenburg position with head above the heart. This helps to prevent blood reflex from Schlemm's canal. It is essential to have a good anesthesia. The patient should be relaxed as well as comfortable. Otherwise, it becomes very difficult for a novice minimally invasive glaucoma surgeon to maintain visualization. In this video, we can see the difficulty in instrumentation due to inadequate anesthesia. There are a wide variety of lens available, ranging from handheld Swan-Jacob lens to hands-free lens and floating lens. A good high-density viscoelastic and a direct gonio lens are the essential weapons for a perfect intraoperative gonioscopy. Apply adequate viscoelastics before docking. Hold the lens in the non-dominant hand and rest the palm on the forehead or the cheek depending on laterality of the eye. Next, identify anatomical landmarks. Scleral spur is the most important landmark. Goal is to achieve an en-face view where coaxial light enters parallel to the iris pointing towards angle. If we place the gonio lens directly without tilting the patient's head or the microscope, no structures will be visible. If either microscope tilt or head tilt is insufficient, we will get something called a top-down view with overlapping of the angle structures. With adequate tilt of both patient's head and microscope, an en-face view can be obtained with clear separation of structures. The path is full of hurdles. The narrow space in the angle can be difficult to navigate, leading to iris damage or corneal damage. Simultaneous intra and extraocular manipulation tends to pose difficulty. Working at high magnification can lead to difficulty in instrumentation as well as visualization at the same time. Here we can see the struggle in instrumentation. Another important hurdle is failure to achieve an en-face view due to improper placement of the lens or the positioning. Small changes can help in troubleshooting. Avoid air bubbles, however small, as it can obstruct visualization at any time point in surgery. Be gentle while holding the gonio lens. Avoid pressure as corneal folds can hamper the view. Bleeding is common during MIGS procedures. Always clear off excess blood before proceeding. So why still blurry? Corneal edema, conjunctivochalasis, surgeon accommodation, or improper zooming are other factors leading to poor visualization. Regular practice is the ultimate secret for a good view. Mastering the art of intraoperative gonioscopy holds the key for a perfect and successful MIGS. Thank you. Thank you, sir.
Can we have the VT93 now? VT93. VT93.
Mystifying the story of manual versus femto CCC.
It's not.
This story has 6 interesting parts: placement, size, shape, creation, centration, and strength. For perfect manual CCC, imprint on the corneal epithelium with the rhexis marker on the visual axis for accurate placement, and enhance this imprint with a drop of dye of methylene blue for a perfect guideline for a manual CCC. In Femto CCC, the laser ensures automatic scanning, detection and placement for a perfect CCC in the center of the bag. Ideal size of a CCC is perfect optic cover. In manual CCC, one has to follow the Rexis marking made on the cornea or the image-guided technology for perfect sizing. Femto CCC is customizable as to the size of the optic. Shape of the manual CCC is guided by chamber dynamics and shearing forces, and therefore consistent shape is always a challenge. It can be oval, pear-shaped, orange-shaped, or even heart-shaped. The Femto CCC is always perfectly circular. Once marked with a Rexis marker, it's important to fill the anterior chamber adequately with viscoelastic till the pupil slightly dilates. Then follow the mark or the image-guided technology to make a perfectly circular round Rexis. But at times it tries to run away in different directions. In such scenarios, one can really rescue it with a microforceps. At times the anterior zonules are weak, so there is no counter traction. Here a dispersive viscoelastic will help you get a perfectly round CCC. In special situations like a manual CCC in hypermature cataract, use of a micro-Rexis forceps to nick the anterior capsule and release the intralenticular pressure. Aspirate the same and inject a dispersive viscoelastic to flatten the anterior capsule and create a Rexis. Another approach to create a spiral CCC in hypermature cataract to prevent an Argentinian flag sign. In creation of a Femto CCC in hypermature cataract, an additional step of staining the anterior capsule with a dye to make sure that the CCC flap is freely floating is quite essential. The creation of the Femto CCC in subluxated cataract is beneficial. One can move the CCC away from the area of subluxation. The CCC then is easily pinched out. Yet another case of subluxated cataract and the creation of the Rexis. In this case, we create a smaller Rexis which is away from the area of subluxation. After the cataract extraction, we place the IOL in the bag, which actually centers in the center of the bag, irrespective of where the CCC is really made. Yet another case of a Femto CCC in a subluxated cataract. Look at the ease of removal of the Rexis, inject the viscoelastic, and we create the space for the endocapsular ring. Femto has definite advantages in difficult cases like 16-cut RK operated patient. Look at the ease of the removal of the CCC. Further applications of the Femto include a case of microspherophakia, a very shallow anterior chamber. One can actually adjust the CCC in the center of the bag and the case can be approached very safely. Another tough case of a posterior polar cataract where there is a pre-existing breach in the posterior capsule. A perfectly rounded CCC is helpful in such cases. In this case, the IOL could be placed safely in the bag.
Nice shot!
In manual CCC, a perfectly centered Rexis on the bag is ensured by marking the visual axis and following it to create the CCC. In Femto, all of this is automated in creation of perfectly round circular CCC. Now we arrive at the most interesting topic of comparison of the strength between manual and Femto CCC. We do know that manual CCC is strong enough to hold on to capsular hooks, but manual CCC can also tear and give way in a simple step of hydro. In this particular case, an MVR nicks the anterior capsule, and that particular breach is included in the boundary of the creation of the manual CCC. This is actually a weak spot. During irrigation aspiration, This is the same spot which is a weak spot. The CCC tears and it gives way. If the femto-CCC is free floating, the CCC is strong enough to hold on to capsular hooks or iris hooks. But if this femto-created CCC is found to have capsular tags, they act as points of weakness, and during irrigation and aspiration, this spot gives way, causing an unexpected capsular tear. Let us see yet another case of a femtorhexis having a capsular tag and the same spot giving way during irrigation aspiration. So if the femto-CCC is not freely floating, it can lead to capsular tears. Adequate placement, sizing and shape in manual rhexis can be achieved by marking the corneal reflex or by following the superimposed image-guided technology. In femto-assisted rhexis, all of this is automated. The benefits of femtorhexis are seen in special scenarios like a hypermature cataract, microspherophakia, microophthalmos, and posterior polar cataract. Subluxated cataracts, where we can actually move the rhexis away from the area of subluxation. While performing femtorhexis in subluxated cataract, we can decenter the rhexis away from the area of subluxation. Having said that, we know that IOL always centers in the center of the bag, and the decentered rhexis can later on be enlarged to get a perfect wraparound on the IOL. The main controversy between manual rhexis and femtorhexis is strength, but we know that manual rhexis stays intact with capsular hooks holding on, but it can give way in a simple step of hydro. Femto-CCC is as strong as manual CCC. It can hold on to capsular hooks as well as iris hooks, but sometimes there are capsular tags left which are weak spots which can give way, leading to capsular tears. Another benefit of the femto-CCC is an accurate IOL centration, a less incidence of IOL tilt and decentration.
Thank you.
Visual impairment. Of all the modalities available in the management of keratoconus, corneal collagen cross-linking is the only one which can hinder or halt the progression of the disease. In 2003, Wollensok et al. Worked on a prospective randomized controlled trial in the University of Dresden, coming up with a conventional CXL or Dresden protocol as we know it. So in the Dresden protocol, the corneal epithelium is debrided, followed by riboflavin application. UVA light, 370 nanometers in wavelength, is given at 3 milliwatt per centimeter square for 30 minutes. But in the same year, the same group led by Wollensok realized that this procedure came with its own set of limitations. Using the Lambert-Beer equation, they came to the conclusion the cytotoxic endothelial UVA irradiance of 0.35 milliwatt per centimeter square was reached at 400 microns. So this poses a problem. Keratoconus is inherently a progressive ectatic disease with progression seen in 25 to 30% cases, and nearly 25% patients presenting with a pachymetry less than 400 microns. Hence, for nearly a quarter of patients with keratoconus, conventional CXL cannot be used as an option. Most of these patients are young, with active hobbies, professional activities, and an entire lifetime to look forward to. So a number of solutions have been devised to circumvent these problems of cross-linking in thin corneas. The first among these is hypoosmolar CXL. While in conventional CXL, riboflavin is used with 20% dextran, which makes it isotonic, hypoosmolar riboflavin is generated by diluting it with physiological salt solution and not using dextran. When in such a solution, the stroma can nearly double in thickness, and Hafezi et al. Used this very property. Hypoosmolar riboflavin was instilled every 20 seconds till the thickness increased to a minimum of 400 microns. A number of studies were conducted, all of which showed stable topography at varying follow-up visits. But this procedure too came with its own set of limitations. The same collagen lakes, which helped increase the stromal thickness, also dilute the number of collagen fibrils available for CXL. The amount of oxygen diffusing through the hydrated stroma also decreases, thereby reducing the efficacy of the procedure. So another way of performing CXL in advanced keratoconus is the transepithelial cross-linking or the epi-on technique. The epi-on technique has shown to result in greater patient comfort, reduced risk of infective keratitis, and decreased incidence of stromal haze post-CXL. The obvious problem is that riboflavin, being a macromolecule, cannot penetrate an intact epithelium. The solution to this is the use of permeability enhancers like benzalkonium chloride and EDTA, which loosen the epithelium, allowing penetrance. The second limitation is that apart from impeding oxygen diffusion, the epithelium itself soaks riboflavin, resulting in its reduced stromal concentration. Wolensack et al. Showed that biomechanical rigidity increased by only 64% after epi-on CXL, compared to a whopping 320% after the Dresden protocol. But enhancers aren't the only way to penetrate an intact epithelium. Iontophoresis utilizes a small electric current to facilitate penetration of an ionized substance across the epithelium. Riboflavin is an ideal molecule for this procedure since it is negatively charged, is water soluble, and has a low molecular weight. The anode is placed on the cervical vertebrae or the patient's forehead, and the cathode is applied to the cornea via a suction ring, and a current of 1 milliampere is given for 5 minutes. Mastro-Pasqua et al. Showed that transepithelial iontophoresis allowed greater riboflavin penetration compared to the conventional epi-on technique. Most studies showed stable results, with Juvitol reporting a 20% failure rate at the 24-month follow-up. The limitations of this procedure resemble those of the conventional epi-on technique. The literature is also sparse, necessitating long-term studies to establish its efficacy and safety. In 2009, Quinones et al. Came up with the idea that instead of debriding the entire epithelium, a customized debridement sparing the epithelium over the cone of the keratoconic cornea can be carried out. While this intact island of epithelium protects the thinnest part of the cornea, the debrided area elsewhere allows increased riboflavin penetration and adequate stromal concentration, resulting in increased biomechanical rigidity. While Quinones et al. And Mazzotta et al. Showed a stable topography, Cagli et al. In 2017 reported a significant endothelial cell loss. The efficacy of this procedure is not yet established, since there is a paucity of studies reporting the outcomes of the same. In 2014, Jacob et al. Had the innovative idea of a contact lens assisted CXL. With a thickness of 90 microns, a contact lens can contribute to the overall thickness of the stroma. In their pilot study of 14 eyes, a BCL or a bandage contact lens was soaked in 0.1% riboflavin for 30 minutes. UVA was given as per the conventional CXL, and all their patients showed a stable topography at the 6-month follow-up. The major limitations include decreased oxygen diffusion and riboflavin concentration in the stroma. In the next year, Sachdev et al. Came up with a rather unique idea of a tailored stromal expansion using the lenticule extracted from patients undergoing small incision lenticule extraction or SMILE for myopic correction. The advantages of this procedure are that the lenticule thickness can be customized as per the patient, and the tissue is biologically similar to the patient's cornea. While this modification was found to be safe and effective in their initial study, it requires long-term trials to establish its safety and efficacy. In 2021, Hafezi and Kling came up with an ingenious solution to resolve this enigma. Instead of attempting to augment the thickness of a thin corneal stroma, why don't we modify the amount of UV light utilized in the procedure? This sub-400 nomogram was devised by estimating the diffusion of riboflavin and oxygen by the fixed diffusion law and ultraviolet energy by the Lambert-Beer equation. They then arrived at this really complicated looking formula, the simplified clinical translation of which is this table, which clearly outlines the treatment times required as per the existing pachymetry values. The obvious advantages are that this procedure can be highly individualized and is independent of the swelling properties of the cornea. The group demonstrated a 90% success rate, allowing for CXL of corneas with a stroma as thin as 214 microns. In summary, there exist innumerable modifications that allow for cross-linking in thin corneas, and long-term trials evaluating their safety and efficacy is perhaps the need of the hour.
Can we have the next video, VT108, Glimpsing the Future, by Dr. Okay. So, VT154, Pythium keratitis versus fungal keratitis, by Dr. Naveen Radhakrishnan. VT154. Can we have the video playing? VT154. It's not there. Next thing. VT406, untying the knots. 406.
Next. 406. Come fast. You are running behind the schedule. Start, please.
VT406, please start.
Goniotomy with the goniscopy-assisted transluminal trabeculotomy has been developed to provide moderate reductions in intraocular pressure. GAT is a conjunctival sparing technique that increases the aqueous outflow by excising the trabecular meshwork all around 360 degrees. It was first described for the treatment of primary congenital glaucoma, but has more recently been reported for adult POAG. Patient selection criteria. A patient should have an open angle in all 4 quadrants for a successful GAT. Instrumentation and arrangements. Direct gonioscopy visualization. Before performing direct gonioscopy, the microscope is tilted 45 degrees towards the operating surgeon and the patient's head is tilted 45 degrees away from the surgeon. Using the right hand, liberal amount of viscoelastic substance is applied over the cornea, and using the left hand, the direct gonioscope is placed over it to visualize the angle structures. Next is the identification of angle structures and locating the trabecular meshwork. Tips and tricks in performing GAT. Filling in the anterior chamber with an adequate amount of viscoelastic substance is important as overfilling of the chamber causes crowding of angles. With an MVR knife, an opening is made in the trabecular meshwork. Blood oozes out from the trabecular meshwork, thereby confirming the correct plane, and the blood is cleared with viscoelastic substance. Using a 5-0 Prolene suture, the appropriate length is measured, cut, and kept ready. Failed mushroom tip with wet cautery. At one end of the suture, initially, wet cautery was used to create a blunt mushroom tip. However, due to insufficient temperature, it failed to produce the desired mushroom tip. Mushroom tip with low temperature dry cautery. It was discovered that using the low temperature dry cautery at the desired temperature, a mushroom tip was successfully created. Kink and suture. The suture should be held meticulously with MSD forceps in order to avoid kinking. Kinking of suture occurs when it is held inadvertently with McPherson's forceps, which hinders the gliding through trabecular meshwork, ending in false pathway. The suture is introduced into the anterior chamber with the blunt end mushroom tip. Difficulty faced with big mushroom tip. A bigger mushroom tip hinders its entry into the Schlem canal. Video showing the failed attempts with a bigger mushroom tip to enter the Schlem canal. Adequate sized tip is necessary for a smooth entry. Smooth entry with small mushroom tip. A smooth glide through the trabecular meshwork is evident in the small mushroom tip. With the aid of MSD forceps, the mushroom tip is inserted into the Schlem canal with a smooth movement. The smooth movement ended in a false pathway. Smooth movement is not enough to confirm that the suture is on the right track. The procedure continued unnoticed despite the resistance encountered after a few passes. It ended in false passage and the suture was visible through the pupillary area when releasing it. The 270-degree, with adequate sized mushroom tip and smooth gliding movement of the suture through 270-degree resistance is encountered. By recognizing resistance at the right time, the procedure was aborted, thus preventing a false pathway. The suture was released, excising the trabecular meshwork. And a successful 270-degree GAT was performed. The 360-degree, with adequate sized mushroom tip and suture, have entered the Schlem canal with smooth gliding movement. Without any resistance, after 20 to 25 passes, the mushroom tip appeared on the other end, the cleft. By holding the mushroom tip, the proximal end of the suture is pulled gently all around 360 degrees in an anti-clockwise direction to excise the trabecular meshwork, and a successful 360-degree GAT is performed. Post-operative tips. The false passage can be identified post-operatively by performing ultrasound biomicroscopy. Summary. GAT is a conjunctival sparing technique that increases the aqueous outflow by excising the trabecular meshwork all around 360 degrees. GAT shows results of 20 to 25% drop in IOP. Learning direct gonioscopy and visualizing angle is the first step in learning MIGS. Microscope tilting towards and head tilting away for 45 degrees is a paramount important step in performing MIGS. Patients with open angle through 360 degrees are ideal candidates for GAT. 5-0 proline suture should be handled without kinking using the appropriate instrument. Adequate sized mushroom tip is necessary for initiating GAT. Smooth gliding movement is of utmost importance for performing GAT. Resistance is the clue to abort the procedure. False pathway is confirmed post-operatively with ultrasound biomicroscopy, UBM. Thank you.
Can Can we have the next video? Video VT154.
Worldwide, a number as big as the current population of Indore is affected by microbial keratitis threatening their sight. Out of these, the majority occur in poor resource settings in South Asian countries with severely debilitating impact on quality of life. 2% of these infections is contributed by Pythium insidiousum. Though a small proportion, its fulminant nature and recalcitrance to therapy make it crucial to be identified at the right time. Pythium is an oomycete with morphological similarity to the microbiological appearance of filamentous fungi. It has a close biological relationship with green algae. The cell wall of oomycetes, however, is made up of beta-glucans and cellulose and lacks ergosterol. This causes antifungal agents to be ineffective against Pythium, making it resistant to therapy given if not identified correctly. Unlike fungal keratitis, majority of the patients infected with Pythium keratitis belong to a non-agricultural background. So features of fungal keratitis in an IT professional, a teacher, a student, or a homemaker should prompt the suspicion of Pythium keratitis. Recognizing specific slit lamp features are pivotal for early clinical suspicion. The first sign being tentacles. Tentacles are long, linear, hyphae-like lesions in the corneal stroma with or without stromal reaction. But not everything that looks like tentacles is Pythium. The margins of this infiltrate resemble tentacles, but this is a dermatitis fungus in hiding. For ease of differentiation, the tentacles of Pythium keratitis appear like long flagellae, while the feathery margins of fungal keratitis appear like short fimbriae. In radial keratoneuritis, seen in acanthamoeba keratitis, the lesion is radial and starts from the
Glimpsing the
limbus,
future,
going along the
illuminating
corneal innervation. The second classical clinical sign is the reticular margin. Fine strands of the white lesion seen in anterior corneal stroma resembles hyphae growth. Also, reticular margins are better appreciated in retroillumination. The third clinical sign is guttering or furrowing. The ulcer in Pythium keratitis progresses circumferentially along with the limbus, mimicking a peripheral ulcerative keratitis. The fourth clinical sign is pinpoint lesions. These are pinhead-like satellite lesions or intrastromal dot lesions arranged at the border of the infiltrate. Satellite lesions of Pythium and fungi can be compared to granular and macular dystrophy. Fungal satellite lesions have an area with an X and Y axis, whereas the Pythium lesions are pinpoint. Like any microbial keratitis, the gold standard for diagnosis is microbiology. Tissue from corneal scraping is sent for staining and culture. Gram stain, on gram staining, Pythium filaments show three classic morphological features: the broad and sparsely septate or aseptate filaments, the ribbon-like folding of filaments, and vesicular extensions. Pythium filaments are broad and sparsely septate or aseptate compared to septate hyphae of fungi. They have a typical ribbon-like folding with truncation at certain points, as shown by the arrow, in contrast to linear hyphae in fungi. The intrahyphal vesicles or vesicular protrusions are depicted by the arrows, which are absent in fungal hyphae. Potassium hydroxide wet mount. Similar morphological features of the filaments, which are seen on gram staining, are seen on 10% KOH. Culture. Flat, partially submerged, glabrous colonies are characteristic of Pythium. Retrospective studies have shown that these clinical and microbial findings have high specificity but low to moderate sensitivity in diagnosing Pythium keratitis. But the story has just begun. Besides being a challenge to diagnose, Pythium is even trickier to manage, with patients responding poorly to conventional antifungal medication or surgical procedures such as penetrating keratoplasty. A giant leap forward in the treatment of Pythium has been the use of linezolid,
I knew it.
azithromycin, itraconazole.
I'm always angry.
In our current battle against the relentless forces of Pythium, we wield linezolid, azithromycin and itraconazole as our formidable weapons. Linezolid stands as our ultimate trump card, boasting an astonishing 80% resolution rate. But sometimes, even superheroes can falter against the mighty strength of Pythium. Then therapeutic keratoplasty emerges as our last, bold confrontation against the unyielding enemy. However, therapeutic keratoplasty bears a grim prognosis with an increased risk of reinfection and graft melt. Perioperative procedures have reduced complications to some extent. But with meticulous history taking, early clinical intuition, recognition of distinct microbiological features, and prolonged antibiotic therapy, we shall triumph.
Next. 108.
Exploring the suprachoroidal space, iStent Supra, MIN inject. By targeting the ciliary body to reduce aqueous production with ECP and micropulse diode laser cyclophotocoagulation. By subconjunctival filtration, MIGS plus, Zen implant, pressor flow. Prerequisite for performing MIGS are direct gonioscopy visualization and identification of angle structures. Direct gonioscopy visualization. Items needed are direct gonio and Sinskey hook. Before performing direct gonioscopy, the microscope is tilted 45 degrees towards the operating surgeon and the patient's head is tilted 45 degrees away from the surgeon. Using right hand, liberal amount of viscoelastic substance is applied over the cornea, and using the left hand, the direct gonioscope is placed over it to visualize the angle structures. A Sinskey hook is introduced into the anterior chamber via the entry wound to get the feel of handling the angle structures. Next is identification of angle structures and locating the trabecular meshwork. To increase the trabecular outflow, excisional goniotomy is performed by BANG, KDB, and GAT. Bent-up internode needle goniectomy. Items needed are direct gonio and 26-gauge needle. Animation showing the excisional goniotomy performed using BANG needle showing irregular leaflets. A goniotome is fashioned by bending the distal 1 mm of a sterile 26-gauge needle toward the bevel using a needle driver. The gonioprism is positioned on the corneal surface. The bent needle is introduced through the corneal incision. The needle tip is carefully guided through the nasal trabecular meshwork into wall of the Schlemm canal and then rotated either clockwise or counterclockwise for about 3 to 5 clock hours to excise trabecular meshwork, depending on the surgeon's preference. Cahoop dual blade goniotomy. Items needed are direct gonio and Cahoop dual blade. Animation showing the excisional goniotomy performed using Cahoop dual blade with without a leaflet and a regular cleft. The gonioprism is positioned on the corneal surface. The KDB blade is introduced through the corneal incision. The blade's sharp tip is carefully guided through the nasal trabecular meshwork against wall of Schlemm canal. The dual parallel blades creates paired parallel incisions in the trabecular meshwork by rotating either clockwise or counterclockwise for about 3 to 5 clock hours, depending on the surgeon's preference. Gonioscopy-assisted transluminal trabeculotomy, GAT. Items needed are direct gonio and 5-0-proline suture. An adequate-sized mushroom tip is made using low-temperature dry cautery with a 5-0-proline suture. After measuring the required length, the suture is cut and introduced into the anterior chamber with the blunt end mushroom tip. With MVR knife, an opening is made in the trabecular meshwork. Blood oozes out from the trabecular meshwork, thereby confirming the correct plane. The blood is cleared with viscoelastic substance. The mushroom tip held with MSD forceps is introduced via the Schlemm canal with smooth gliding movement all through 360 degrees. After 20 to 25 passes, the mushroom tip appears on the other end, the cleft. By holding the mushroom tip, the proximal end of the suture is gently pulled all around 360 degree in anti-clockwise direction to excise the trabecular meshwork for a successful GAT. Aqueous outflow can be increased by bypassing the trabecular meshwork with iStent Generation 1 and iStent Generation 2. iStent Generation 1. Items needed are direct gonio and iStent Generation 1. Here we are implanting the G1 iStent into the trabecular meshwork with a proper gliding technique to ensure the proper placement within the angle. Following which we can release the trocar and assist the placement of iStent into the trabecular meshwork. And a functioning trabecular outflow system can be seen by the blood flow within the collector channel from the position of the iStent. iStent Generation 2. Items needed are direct gonio and iStent Generation 2. For proper placement of the G2 iStent, we need a proper dimple at the angle depicting good firmness to ensure that the iStent is well placed within the trabecular meshwork. And additionally, a second iStent is placed in the similar manner at least 1 to 2 clock hours apart. Here we can see the two iStents adjacent to each other via the limbus. We can see the area of paralimbal blashing, which depicts successful outflow. Mixed MIGS. It is performing two techniques from the same category to provide better IOP control. iStent with bang and iStent with KDB. iStent Generation 1 with bang. Items needed: direct gonioscope, iStent Generation 1 and 26G needle. In this case, with the implantation of G1 iStent, an additional MIGS procedure was done. Here we did the bent of internode needle goniectomy on either side of the implant at least 1 clock hour apart to ensure an additional outflow via the trabecular meshwork. iStent Generation 1 with KDB. Items needed: watch 0.2s direct gonioscope, iStent Generation 1 and KDB. Here we have a case of G1 iStent implantation, which was successfully implanted into the trabecular meshwork. Following which an additional MIGS procedure was performed, the Cahoop dual blade goniotomy on either side of the implantation at least 1 to 2 clock hours apart to increase the outflow via the trabecular meshwork. ECP. In order to decrease aqueous production, endoscopic cyclophotocoagulation (ECP) is performed. The 23-gauge probe is inserted into the anterior chamber through a clear corneal incision to visualize the ciliary processes. Laser energy of 0.2 to 0.25 watts is delivered to the ciliary processes to achieve blanching and contraction of the ciliary processes, depicting photocoagulation and coagulative necrosis. Compound MIGS. It is a new novel technique of handling both inflow and outflow pathways, namely the ciliary process and trabecular meshwork by ECP and bang technique for adequate control over IOP. Summary. MIGS is an option for a variety of glaucoma from congenital to adult, mainly POAG, but now also tried in select ACG. Can be an option after failed trab or tube, especially where there is no conjunctival tissue available. Broadly classified into two types: TM-targeted, incisional and implant, and ciliary body targeted. Learning surgical gonioscopy in phaco patients is the first step in learning MIGS and will help visualizing angle. Need to turn head away, 45 degree, and microscope towards surgeon to visualize angle. IOP lowering effect studied longest for iStent in 5 years, while for other technique, GAT, bang, KDB, 1 to 2 year follow-up data available. Both have comparable results, 20 to 25% drop in IOP. The ultimate long-term success will depend on patency of collector channels, which at this point can't be judged by any gold standard diagnostic test. MIGS has given one more surgical tool in our hands, especially in mild or moderate glaucoma, to avoid trab or tubes, preserving conjunctiva for future need, and by reducing medication burden, with all its side effects as well. As an innovative advancement, we have put forth two new novel techniques, namely mixed MIGS, compound MIGS, which provides an added advantage of better IOP control. Here we can see the post-op gonioscopic view along with its anterior counterpart. Each anterior scan has its own unique features. Finally, we have created a holographic MEGS metaverse simulator with detailed angle structures, where neophytes can train themselves. Thank you.
Excuse me, whose voice is that?
Automated.
A rare ocular challenge. This film provides an in-depth exploration of a rare, vision-endangering type of keratitis known as Pythium insidiosum keratitis. Pythium insidiosum is an oomycete which causes rare vision-threatening keratitis in humans. Pythium keratitis closely resembles fungal keratitis and is also known as parafungus. This disease presents a significant clinical, morphological and microbiological diagnostic challenge. This diagnostic enigma has long puzzled medical researchers and clinicians. This disease has been predominantly reported in tropical and subtropical regions, including Thailand, the United States, China, Israel, Australia, and India. The first case of systemic pythiosis in a human was reported in Thailand in 1985. However, the first case of Pythium keratitis was reported in 1988, and since then, large-scale studies from all over the globe. It affects all age groups, with a higher incidence in certain professions. Studies quoting the incidence and prevalence of Pythium keratitis are scarce in literature due to the rarity of the organism. It is important to understand the hallmark clinical features of Pythium insidiosum keratitis to distinguish it from other close mimickers. The typical clinical features that distinguish it from fungal keratitis are patchy reticular dot-like subepithelial and stromal infiltrate, multifocal infiltrates, cotton wool-like stromal infiltrate with hyphated edges, peripheral furrowing, early limbal spread, and peripheral corneal thinning with guttering and tentacular projections. In recent years, there's been a notable increase in Pythium keratitis cases, thanks to heightened clinical awareness, better diagnostic tools, and more research into treating this severe condition. Its symptoms often resemble those of other types of keratitis, making diagnosis challenging. However, its resemblance to fungal, mycobacterial, acanthamoeba, and bacterial keratitis complicates diagnosis. These similarities in clinical features demand a high level of suspicion and careful differential diagnosis to identify and treat Pythium keratitis effectively. Systemic associations. This condition is associated with various systemic diseases, including paroxysmal nocturnal hemoglobinuria and aplastic anemia, among others, further complicating the clinical picture. Laboratory investigations play a key role in early diagnosis and targeted treatment of Pythium keratitis. Corneal scraping is done under topical anesthesia using a chemora spatula or a Bard Parker blade. The samples undergo gram stain and potassium hydroxide wet mount tests, followed by culture on sheep blood agar and potato dextrose agar. The growth characteristics of Pythium species are observed under specific incubation conditions. Histopathological stains such as hematoxylin and eosin, periodic acid Schiff, and gomori methenamine silver are used on formalin-fixed, paraffin-embedded samples to identify Pythium filaments. Various staining durations and reactions are employed to confirm the presence of Pythium. Molecular diagnostics such as polymerase chain reaction, PCR, targeting specific regions in Pythium's ribosomal RNA is used for species identification. Different genes and regions are targeted for phylogenetic studies. Duplex PCR and DNA sequencing methods have also been developed for more efficient diagnosis. Serological tests include Western blot, enzyme-linked immunodiffusion assay, immunodiffusion, and hemagglutination assay. Serological tests detect antibodies against Pythium in serum, with varying degrees of sensitivity and specificity. Each method plays a crucial role in identifying this elusive organism. Treatment strategies for pythiosis. Antifungals, initially, drugs like natamycin, voriconazole, and itraconazole were used, but they have limited success. They are started before culture results and switched to targeted treatments once results are available. antibacterials. For confirmed cases, a regimen of topical linezolid and azithromycin, along with oral azithromycin, is recommended. Treatment success is monitored through regular follow-ups and clinical signs of improvement. But often surgical intervention like therapeutic and tectonic keratoplasty are mandated for severe non-resolving cases. Adjunctive treatments techniques like cryotherapy with ethanol and the use of cyanoacrylate glue with bandage contact lenses are employed for better outcomes and to prevent recurrence. Post-operative management is critical for recovery and good outcomes in these cases. This includes continued use of antibiotics, adjuvant drugs to manage symptoms, and careful monitoring for complications like cataracts and glaucoma. Graft survival is a significant concern, and regrafting might be necessary for visual rehabilitation. Patients should be counseled about the disease prognosis and future follow-ups. Pythium insidiosum keratitis can be mistaken for fungal keratitis due to similar clinical, microbiological, and histopathological features, especially in cases that do not respond to typical treatments. The other close mimickers are bacterial keratitis, acanthamoeba keratitis, peripheral ulcerative keratitis, and atypical mycobacterial keratitis. Differential diagnosis is key, as Pythium keratitis can mimic other forms, leading to mismanagement. Early detection and correct identification are vital for effective treatment. Complications are usually vision-threatening and include secondary glaucoma, corneal perforation, corneal melt, retinal detachment, choroidal detachment, recurrence of infection, and phthisis bulbi. Systemic complications such as cavernous sinus thrombosis, systemic vasculitis, paroxysmal nocturnal hemoglobinuria, and aplastic anemia are severe and can even lead to death. Our novel diagnostic and treatment algorithm aims to improve outcomes through dynamic and targeted approaches. This is the diagnostic and management algorithm proposed by Gurnani et al. Thus, to conclude, as we decode the mysteries of Pythium insidiosum keratitis, we open new
Heavy cost of complications. Though we expect and wish every surgical outcome with low diffuse blood and smiling face of the patient, unfortunately, we have to face several complications ranging from shallow anterior chamber, bleb bleed, blebitis, hypertony, and choroidal detachment. Increasing patient quality of life and decreasing the rates of postoperative complications have been the driving forces behind the development of conjunctiva-sparing minimally invasive glaucoma surgeries. Various MIGS techniques have been described since 2000s. Among those, the gonioscopy-assisted transluminal trabeculotomy was first introduced in 2014 by Grover et al. GAT attempts to disarm the resistance from the trabecular meshwork and restore a more natural outflow of aqueous fluid within the eye. Though it is technically demanding, it provides a very cost-effective MIGS procedure when a polypropylene suture is used. Let's look at some complex case scenarios. So here is the case of 25-year-old female who was diagnosed with juvenile open-angle glaucoma in both eye with advanced cupping and uncontrolled intraocular pressure despite maximal medical therapy. This is the fundus picture showing advanced cupping in both eyes with advanced field defect in both eyes and early field defect in left eye, and OCT corroborating with the above findings. The patient underwent right eye combined trabeculotomy with trabeculectomy. After 2 weeks of surgery, the intraocular pressure was 6 mm mercury. But at 2 months postoperative period, the intraocular pressure dropped to 4 mm mercury with the patient developing hypotony maculopathy. At 3 months post-op, the intraocular pressure remained low at 3 mm mercury with persisting hypotony maculopathy. This is the OCT picture showing hypotony maculopathy in the patient. So what to do next in the left eye? For the left eye, the patient was planned for gonioscopy-assisted transluminal trabeculotomy, considering the high intraocular pressure and the complication in the right eye. After putting adequate viscoelastic and docking the gonio lens, a goniotomy was made and the Schlemm's canal was exposed. Then the blunted proline tip is introduced into the Schlemm's canal and threaded slowly along the Schlemm's canal 360 degree. In small strokes, the proline suture is pushed gently. When the tip appears on the other side, it is gently grabbed using the max grip forceps and the 360 degree GAT is completed. Postoperatively, the patient's intraocular pressure was under good control and thereby avoiding complication as well. Next is the 60-year-old female patient who was a known case of primary open-angle glaucoma and was on maximal medical therapy. This patient had advanced glaucoma and uncontrolled intraocular pressure. The field report showing the uncontrolled nature of the glaucoma and the advanced field defect almost approaching fixation. This patient underwent gonioscopy-assisted transluminal trabeculotomy with phacoemulsification in the right eye, and the intraocular pressure control was really good in this patient. This is a video showing the GAT procedure being performed in the right eye of the patient. The blunted proline suture is introduced through the paracentesis. After applying adequate and liberal viscoelastics, the direct gonio lens is docked onto the cornea. Schlemm's canal is exposed and the blunted proline trip is introduced. And the 360 degree gonioscopy assisted transluminal trabeculotomy is completed. Assisted transluminal trabeculotomy of the same patient for the other eye, and the procedure is the same.
The problem is you're streaming it from your server and there's not enough buffer. You should have just downloaded all the files to the server, from the server to your computer in this room, so you can play them directly. I mean, I'd help you more, but then I got to charge you, right?
Vanquish the hurdles of and the blunted proline trip is introduced.
We're going to be here until midnight tonight. It's going to be a long night. I'm going to miss my flight home.
Move to the next video. VT 143.
DIY for glaucoma procedures. Practice makes a doctor perfect. Glaucoma is the leading cause of irreversible blindness in the world. By 2040, around 112 million people in the world will be affected by glaucoma. But are we having enough glaucoma specialists to tackle this burden? The number of ophthalmologists worldwide is estimated to be 2 million, but many of them do not operate or do only a few number of surgeries. Welcome to the world of glaucoma fellows. After completing clinics, enthusiastic glaucoma fellows walk towards the wet lab, chattering away happily, discussing what to practice on the goat or human eye. To their disappointment, they find that there are no goat eyeballs to practice that day. So, no wet lab practice, but tomorrow is the operating room posting. Necessity is the mother of invention, or rather innovation in our case. An idea pops up. Here begins the journey for the do-it-yourself glaucoma project. First, we had to create an alternative to goat or human eyeballs for wet lab practice. We thought of silicone eyeballs. They are a good, reusable option, but a bit costly and difficult to find and maintain. So we thought of making our own practice eyeball. We took a pair of gloves, cut out the finger, and filled one finger with water. Another with leftover viscoelastic, and the third with toothpaste. We tied them up with an elastic band of used masks. Then we mounted it on a used keratome with its cover and used its handle to hang the eyeball on the slit lamp. Let's see what problems got solved. We tried measurement of IOP by eye keratinometer, tonopen, applanation tonometer, central corneal thickness by ultrasound pachymetry. One can hold it like an eyeball vertically and practice as in a human eye. All of our nurses, students, and consultants tried it and liked it. But we wanted to explore more possibilities. So we thought, can we mimic surgical procedures? Then we tried doing AC decompression using a 26-gauge needle. We tested with water, but it collapsed once it was punctured. Then, next, we filled the glove finger with viscoelastic because it was transparent and at the same time more viscous. Next was blood needling, for which we used red toothpaste to get the red glow and better visualization. We marked the limbus and scleral flap on the model eyeball and utilized a 26-gauge needle to practice blood needling. Then we thought, what about lasers? So we created two models. First, we used a suture sponge with pre-placed sutures on it in radial fashion mounted on a used keratome for practicing laser suture lysis. This served two purposes, practicing suture placement, and second, of the laser suture lysis using double frequency Nd:YAG laser. We made another eyeball for laser peripheral iridotomy, for which we used 1. Old trial lenses, ones with the glass to mimic the cornea and ones without the glass to give a little bit of depth to mimic the anterior chamber. 2. A carbon paper to mimic the iris. 3. A waste bottle cap, preferably red, which acted as the posterior segment and the red contour mimicked the fundal glow. 4. Micropore to tie it all up together. 5. Used keratome to mount on the laser slit lamp. We finally tried working on the plan for which all started, to learn to raise the flap. So, we took the waste sponge, marked the specifications of the flap with calipers, and raised the flap with a blade. And sutured the flap. The sponge gave the feeling of the sclera indeed. Finally, the happy moment arrived. Having practiced almost all the instruments, flap raising, suturing, and laser suture lysis, the fellows felt more confident in the OR and in the clinics. This video shows that where there is a will, there is a way, and nothing can stop if a student wants to learn and a teacher wants to teach. Thank you.
Next video, VT537.
Open source 3D printed surgical instruments demonstrated in virtual and physical reality by John Davis Akkara and Dr. Anju Kuriakose. The authors have no financial interest in this presentation. We are releasing the designs open source and free on Thingiverse and National Institute of Health 3D Print Exchange. It is difficult to be prepared for complex eye surgeries using CTR, CTS, Seone ring, BHEX pupil expander, and different phaco choppers and glaucoma drainage devices. We decided to design and 3D print devices that aid in complicated cataract surgeries such as CTR, CTS, Seone ring, BHEX ring, glaucoma drainage devices for wet lab practice. I used 3D computer aided design and 3D printing to design and print the glaucoma valves that we are talking about. So I used a free software called FreeCAD and drew the design of the valve which I had in mind. That was the foot plate. And once I had drawn the design and finalized it, I took it to 3D printing lab and used the resin 3D printer to print the model. There are two types of easily available 3D printers. One is the resin 3D printer and the other is the plastic 3D printer which uses spools of plastic. Once the 3D printed footplate was printed, I removed it from the mold, cleaned it with isopropyl alcohol, and then kept it under UV light. And once that was done, the footplate was ready to use. I used the tube from a Venflon to make the tube of the valve. Once the tube was cut, it was inserted into the hole of the footplate. And so this is the footplate and the valve mechanism, and that is the tube. If you look at the other side of the valve, there are 6 canals opening in 3 in each side. These allow the liquid to flow in from the tube. We then fixed a bow tie in a plastic container and did a conjunctival peritomy to insert the valve. The footplate of the valve is carefully inserted under the conjunctiva. Make sure that the conjunctival opening is big enough to accommodate the footplate. The footplate is then anchored to the sclera by suturing through the 4 holes using Vicryl sutures. The tube is then measured and trimmed with the scissors. Once this is done, the next step would be to implant the tube into the anterior chamber. We have to make a track using a needle, partial thickness through the sclera into the anterior chamber in case of phakic eye, and into pars plana in case of a pseudophakic or aphakic eye. Next step is to insert the tube into the tunnel so that it reaches the anterior chamber. Once the tube is inside, we have to make sure that it does not touch the endothelium. These are some of the other valves that we 3D printed compared to the first valve, which was actually quite big. The biggest one is the first GDD that we implanted in the surgical video. There is the small one with the tube, which is the latest design as of now, and there is also a medium-sized one. This is a top and bottom view of the first valve that we designed. We can see the flow of fluorescein dye through all the 6 channels in the valve conduit. This is a medium-sized valve, top and bottom view. This is a design for the smallest and newest model that we had designed. This has a raised area on the top through which the tube is inserted, and it has multiple channels which channel the liquid into the bottom. The plate itself has multiple holes to allow fluid pass through into the subconjunctival space. The fluid flow is as seen in this video. Here you can see the various CTR, CTS, Seone ring, BHEX pupil expander, and glaucoma drainage devices made by 3D printing. We have published an article in the Kerala Journal of Ophthalmology called The Magic of Three-Dimensional Printing in Ophthalmology, where we have discussed the various uses of 3D printing in ophthalmology, including ophthalmic surgical instruments and devices. Several surgeons have used 3D printing for prototyping, including customized vitreoretinal forceps by Dr. David Chow, blepharoplasty instruments by Kotles, modified muscle hook by Dr. Danny Sow, and the pupil expansion device Canabrava's ring by Dr. Sergio Canabrava from Brazil. Our very own Dr. Suvain Bhattacharya has also used 3D printing to design the holder and storage case for the BHEX ring, pupil expander ring. There are also several other uses for 3D printing, including the smartphone-based fundus cameras, including the foldable fundascope, Jaundas foldable fundascope, smartphone-based slit lamp imaging adapter that we have published along with Dr. Ahmed Ataya in the Kerala Journal of Ophthalmology. Even spectacles and lenses, including transparent lenses, devices for patients, including an eye drop helper and the glass dropper by Dr. Pavan, and eye drop helper by Dr. Shivagami. Surgical planning by using the 3D prints from the CT scans and MRI scans. Even optical coherence tomography 3D scans can be 3D printed. The 3D printed toys for the blind, Twiddle by LV Prasad Eye Institute, is available. Bioprinting can be used for 3D printing cornea, that is also recently available. The 3D printed designs that we have created have been uploaded for free download on thingiverse.com and also in the National Institute of Health 3D website, that is the 3d.nih.gov of the USA. The Thingiverse website, you can see the various devices such as the BHEX pupil expander, the capsular tension ring, capsular tension segments, and so on. If you click one of these, so once you put it in 3D mode, you can rotate it and look at the design and then 3D print it. If you look at the NIH website, Orolog Aqueous Drainage Implant, the RD, and this is a 3D model which is also 3D printable in the resin mode. So these are the two websites where this has been uploaded and you can download them for free. After you download, what do? You can go to Google Maps and find a 3D printing shop near you. So for example, this is in Thrissur. You can look at the various reviews and photos posted. This is a resin-based SLA stereolithography 3D printer, and these are all resin printed models. This is the filament-based FDM printer. You can do FDM printing as well as resin printing here. So thank you. I hope this will help you to 3D print your designs.
Can we have the next video, VT297?
Differentiating orbital fat prolapse from dermolipoma, the good fat and the bad fat. Both subconjunctival fat prolapse and dermolipoma present clinically as fatty epibulbar masses in the lateral corner of the orbits. However, they are two distinct entities. In this video, we illustrate the differentiating features of each and demonstrate their intraoperative appearances. Both fat prolapse and dermolipoma are benign entities. Fat prolapse is an acquired lesion characterized by anterior herniation of intraconal fat due to weakness of the Tenon's capsule and the intermuscular septae due to aging, trauma, or surgery. It is typically bilateral and more common in obese men in their 7th or 8th decades of life and manifests as a soft yellowish mass with a convex anterior margin. It is easily depositioned into the orbit and becomes more prominent by retropulsion of the globe. In contrast, dermolipoma is a congenital choristomatous tumor. It is usually present at birth and is more common in young women. They are soft or firm pinkish yellow mass with a slightly concave anterior margin, frequently accompanied by dermis-like connective tissue and fine hair on the surface. It cannot be repositioned into the orbit. It may be associated with Goldenhar syndrome, which includes limbal dermoid, eyelid coloboma, and preauricular skin tags. The most important radiological finding in fat prolapse is the continuity of epibulbar mass with the intraconal fat with similar fat-like signal intensities. On the other hand, dermolipoma appears as a crescent-shaped fatty mass in the temporal aspect of the orbit, not in communication with the intraconal fat. There is often heterogeneous soft tissue intensities within the mass. The surgical excision of fat prolapse is quite straightforward. The lacrimal gland here is seen away from the yellowish mass of fat prolapse. The conjunctiva is incised at the height of the mass using monopolar radiofrequency cautery as posterior as needed so that the wound is well within the fornix. Once conjunctiva is open, we find a thin layer of tenons as the plane of the fatty mass is subtenons. As we dissect all around, bare sclera starts to be visible. The base of the fat is crushed with artery forceps in order to achieve hemostasis before excising the fat with bipolar cautery. The remaining fat retracts into the orbit naturally. Fibrin glue is used to secure the conjunctiva onto the sclera. One may also use ligatures to represent the fat, which is often not required, or sutures to close the conjunctiva. In dermolipoma, the overlying conjunctiva may be adherent to the dermal component. Marking is done around the adherent patch. Monopolar radiofrequency cautery is used to dissect the conjunctiva all around the mass. The bubbly architecture confirms the subconjunctival plane, which is the plane of the lesion, unlike in fat prolapse, which is subtenons. Dissection is completed all around. As the incision is away from the supratemporal fornix, there is no risk of damage to the lacrimal ductules. The intact tenons capsule is seen covering the sclera. The conjunctiva is then simply secured with fibrin glue. Histopathological study of fat prolapse shows characteristic signet ring-shaped adipocytes within lobules of adipose tissue with fibrovascular septation. Dermolipoma shows lobules of fat as well, but in addition depicts collagen that resembles dermal collagen, hence the name dermolipoma. It is important to differentiate orbital fat prolapse from dermolipoma, as they have distinct anatomical relationships which need to be borne in mind during surgical excision. Both entities have excellent cosmetic outcome following minimally manipulative surgery.
Can we have the next?
To achieve a satisfying intraocular pressure level because of dysfunctional trabecular meshwork. In such cases, combined phacoemulsification along with goniosynostolysis and GAT are found to achieve target IOPs. So this is the patient who is a 52-year-old female patient who is a known case of angle closure glaucoma and advanced cupping in both eyes with uncontrolled intraocular pressure. This patient underwent YAG peripheral iridotomy after controlling the intraocular pressure. The patient was started on maximal medical therapy, and after adequate control of intraocular pressure, the patient was planned for goniosynostolysis with gonioscopy assisted transluminal trabeculotomy along with phacoemulsification. The goniosynostolysis was achieved using a Tenito microhook. The Tenito microhook is introduced through the paracentesis and gentle goniosyneculasis is being performed. After achieving the goniosyneculasis, the blunted proline tip is introduced and goniotomy is done. The Schlemm's canal is exposed in the nasal quadrant and the proline suture is threaded and the procedure is performed. The same patient underwent GAT with phacoemulsification within a gap of 2 weeks. The microscope tilt and the patient positioning is one of the key factors for a successful GAT. Postoperatively, the intraocular pressure was well controlled in both eyes without any complication in the patient. The most common complication following a GAT procedure are hyphema and transient intraocular pressure spikes. The hyphema occurs when Schlemm's canal is filled with blood due to the reflux from the episcleral veins after the circumferential rupture of the trabecular meshwork. The transient IOP spikes are related to prolonged hyphema and can be eliminated by washing out the anterior chamber. For a successful GAT, the practice of intraoperative gonioscopy with direct gonio lens in phaco procedure should be started first. The microscope rotation to 35 degree towards the surgeon and patient's head 35 degree away from the surgeon for an en-face view of the trabecular meshwork. Keep the anterior chamber formed at all the times using good viscoelastic. The proline end of the suture should be blunted with cautery and avoid any air bubble between the lens and the cornea. To conclude, GAT is a safe procedure which can be considered in varying spectrum of glaucomas due to its high safety profile and intraocular pressure lowering efficacy.
Can we have the next one?
Are you shaving your head?
We're going on an epic adventure, Morty.
What?
Get retinal tears.
Are you shaving your head?
We're going on an epic adventure, Morty.
What?
Get retinal tears, Morty. Fresh with bleed. Old detachments. With macular hole.
What does shaving your head have to do with...
Why do we have to do anything, Morty?
I don't know.
That's good, Morty. Find your motivation. We have to make choices and we have to face the consequences. We're going to the 9 realms.
Oh!
When it comes to tears, Marty, it's not all about tears. It's about quick cheers. So put your truck to Ringer and cut all you can like a piranha in action.
Oh my god! Look at the size of the drake! And is that a macular hole?
I want to say that size don't matter, but here I will agree with you. But worrying doesn't suit us retinal surgeons. Sometimes we just have to be creative. Let's cut a piece of this interior lip, and we will use it as an autograft for our macular hole. Tuck it nicely. Now you have to put some perfluorocarbon. Stabilize your posterior pole. Nitromize the edges. An endolaser like its vision depends on it, because it does. Do your perfluorocarbon and siliconal exchange, and hope for the best. Sometimes science is more art than science, Morty. A lot of people don't get that. Let's look at the post-ops. These are our post-op day 1 and post-op day 7 scans. We can see our retinal autograft here, and the retina is on. I might as well say the surgery was a success. Moving on to another adventure. Fast, but not furious. This is a child with Stickler syndrome. He came to us with sudden loss of vision for 1 day. We planned immediate vitreoretinal surgery. A good, steady, thorough vitrectomy saves your day, any day. You have to set your parameters right. High, cut rate, and low, vacuum, so that your retina behaves. Here we are trimming the horns of the GRT. Rest, you know the drill. Put perfluorocarbon to flatten the retina. 360-degree endolaser. Perfluorocarbon and siliconal exchange, and your eye is set. And ladies and gentlemen, that's what we call a good outcome. In our next adventure, I'll paint you the picture first.
8-year-old child has come to our clinic status post-orneus laural tear repair. This is his abuse scan, and you'll be of service here.
Well, let me check my list of powers and weaknesses. Ability to do anything, but only whenever I want. Yeah, it sounds like a job for me. What we could see at this point was a bolus detachment, so we chose a 20-gauge cannula. Next step was vitreous debulking. Membrane dissection to free the edges was started. What we realized on our way, that the nasal retina continued anteriorly with no edge whatsoever, exactly towards the site of corneoscleral repair. Now we have to create the edge, and that's why nasal retinectomy is being done. Went with perfluorocarbon to unfurl the retina. But then this happened. Watch closely. This clearly indicates towards leftover traction. Hence further search for membranes commenced. We saw some subretinal vitreous in heme earlier, so it would not be outrageous to assume the presence of subretinal gliosis and vitreoretinopathy. For the moment of truth now, on re-injecting perfluorocarbon, look at this beauty unfolding. Finishing the endolaser under the perfluorocarbon. The perfluoro and siliconol exchange, and the case was closed. For the post-ops, I'll let the picture speak for itself. What do we learn here? To live is to risk it all. Otherwise, you're just an inert chunk of randomly assembled molecules drifting wherever the universe blows you. Kids, for the last show.
What is so special about it, sir?
Here you are wrong. All giant retinal tears are special, and we should never take things for granted. This surgery is to reinforce the basic steps that we have seen till now. Port for chandelier illumination is being made. Corvitrectomy is done. Trimming of the horns help us ensure that there are no residual vitreous strands. For peripheral vitrectomy, intravitreal triamcinolone acetonate can improve our visualization. Ensure a thorough peripheral vitrectomy. Perfluorocarbon is injected using a dual-bore cannula. Once the retina is enfolded, endolaser is done under perfluorocarbon. Perfluorocarbon and siliconol exchange is done. I have noticed less slippage of retina with this technique. These are the post-op results of this patient. All right, listen to me, Morty. I know that these situations can be intimidating. Meeting them head on, charging right into them like a bull, that's how we grow. Don't ever forget your basics. Don't be the bird who'll fall once the branch breaks.
Can we have the next video?
Capillary hemangioma with chorioretinectomy. Retinal capillary hemangiomas are one of the earliest manifestations of the VHL disease. They can be solitary or multiple and may present small tumors in the periphery that are amenable to treatment with laser or cryoablation. However, large tumors often present with exudative, tractional, or a combined retinal detachment and may require surgical intervention with en bloc resection of the tumor, either transscleral or internal. Surgical removal of tumors may be challenging due to the high risk of intraoperative bleeding while resecting the highly vascular tumor. Similarly, postoperative proliferative vitreoretinopathy may lead to recurrent retinal detachment and surgical failures. Prophylactic chorioretinectomy was first described by Frank Kuhn in severe trauma cases for prevention of proliferative vitreoretinopathy. It has also been used successfully in cases of choroidal melanoma undergoing endoresection. In this video, we present a case of a large capillary hemangioma with retinal detachment which was managed by endoresection and chorioretinectomy. A 20-year-old male presented to us with diminution of vision in right eye since 5 months. There was a large retinal capillary hemangioma and a retinal detachment. On B scan, the retinal hemangioma appeared to be adhered to the choroid and there was evidence of retinal detachment. The patient was planned to undergo pars plana vitrectomy with endoresection of the tumor, endolaser and silicon oil injection. After achieving a posterior vitreous detachment and removing the cortical vitreous, the posterior retina was stabilized using perfluorocarbon liquid. A thorough dissection of the vitreous base followed this. The vitreous base was stained multiple times with triamcinolone acetonide to ensure complete removal. A 360-degree endocautery was performed around the tumor, including the feeder vessels. The intraocular pressure was then raised to 60 mm mercury on the Constellation Vision system, following which the hemangioblastoma was removed piecemeal using the cutter. Since the tumor adhered to the choroid, a localized choroidectomy was also performed, leaving a bare sclera. Further hemostasis was achieved using endocautery. Fluid air exchange was done, followed by endolaser, and the case was closed under silicon oil. At 1 month follow-up, the retina remained attached with no evidence of proliferative vitreoretinopathy. To conclude, endoresection with chorioretinectomy can be safely done in patients with large retinal hemangioblastoma and retinal detachment, especially if the tumor is adherent to the underlying choroid. Thank you.
Surgical management of retinal detachment either involves a scleral buckling, a pars plana vitrectomy, or a pneumatic retinopexy. Whenever we do a vitrectomy, we do end up using conventional oil or gas tamponades. However, they come with their own set of problems. And therefore we decided to explore the use of fibrin glue in these cases instead of silicone oil or gas tamponades. Now, fibrin glue is a mixture of aprotinin, fibronectin, and plasminogen, and has already been used in intraocular surgeries for even optic disc pit associated macular detachments. It's an agent which has already been proved to have no retinal toxicity. So the surgical technique involves doing a complete vitrectomy like what we would have anyways done. Then, in an air-filled globe, after settling the retina, we do a laser around the break. Subsequently, again in an air-filled globe, now over the lasered break, instead of putting oil or gas, what we do is we put a drop of fibrin glue so as to cover the break, and no postoperative positioning needs to be given for this patient. So this was a 63-year-old gentleman who came to our clinic with a visual acuity of 20/200 and inferior detachment with an inferionasal break, which was noted. A complete pars plana vitrectomy was done and all the vitreous was removed. The break was marked with diathermy. Now a fluid air exchange was done and the retina was settled. After settling the retina, laser was done around the break, and after completion of the endo laser, in an air-filled globe, one drop of a thick component of fibrin glue followed by one drop of thin component of fibrin glue was placed over the break. After waiting for 5 minutes, a coagulum gets formed, and this coagulum can be easily lifted and deposited and placed with the help of a forceps to cover the break. So the idea is to ensure that the coagulum covers the break completely. After this, fluid was switched on again and the entire air was removed from the vitreous cavity. We found that the retina was completely attached with the coagulum of fibrin covering the break. We confirmed the fact that the retina was attached with the help of an intraoperative OCT. The eye was closed and post-operatively subconjunctival dexamethasone was injected to prevent any untowards inflammation the next post-operative day. On the first post-operative day, we found an attached retina with a fibrin coagulum covering the break, and the visual acuity had improved to 20/80. At 1 week, we can note that the coagulum has nearly gone away. The visual acuity has improved to 20/60, and at 2 weeks now, the visual acuity is 20/60 with a completely absorbed fibrin coagulum. So fibrin glue assisted surgery is a promising technique for treatment of uncomplicated simple rhegmatogenous retinal detachments. It allows for an early visual recovery while avoiding the usual problems of gas or oil tamponade and obviates the need for a post-operative positioning.
Can we have the next video, VT448? Can you please play the video?
I'd fight all that it takes to save a life. Retinoblastoma, one of the most common ocular tumors in children, can have devastating outcomes if not treated on time. Many children can lose both their eyes to the disease. Here is a case of one of our warrior babies and the fight that prevailed to save his only seeing eye. A 2-month-old boy with family history of retinoblastoma presented to us. His left eye was enucleated and right eye showed group E retinoblastoma with exudative retinal detachment. He underwent 6 cycles of systemic chemotherapy and TTT to the active tumor. At age of 18 months, the tumor was stable, but he presented with a metagenous retinal detachment with a peripheral break. A scleral buckling was performed for the same, and at 4 years, he underwent lens aspiration with IOL. However, at 7 years, he had a recurrent RD, so we planned a vitrectomy with drainage retinotomy, endolaser with silicone oil tamponade. Trichode-assisted PVD induction was done, followed by completion of the vitrectomy. Following which PBG dye-assisted ILM peeling was done. As the break was not identified, a drainage retinotomy was performed, followed by fluid air exchange. Endolaser was done around the site of drainage retinotomy and around the site of calcium plaque, which was the suspected site of break. Unfortunately, 4 months later, the RD persisted. The yellow star shows the site of suspected break, and the white arrow shows the area of lifted retina. With not many options left, we thought a macular buckle would save the eye. The primary scleral buckle was removed and the macular buckle was placed in position. This shows the surgeon indenting to make sure that the break was on the buccal summit. To our dismay, however, the RD persisted. Relaxing retinectomy was not an option considering the large area to be dissected and the tumor involvement. Our final strike was a tumor fracture 4 months later. The plaque over the site of suspected break was dissected carefully and released with forceps and the cutter. Hemostasis was achieved, followed by fluid air exchange, endolaser around the site of break, and a silicone oil tamponade. Although our path to success was very long, did we succeed? We did emerge victorious. This was the immediate post-op OCT. And this was the OCT 18 months later, where the child regained a visual acuity of 20 by 120, and this remains for a follow-up of almost 7 years. This was our victorious tale of the one-eyed fight. We were also able to save both eyes of his younger sibling with retinoblastoma due to timely intervention and surgery. Thank you for watching.